Hi, how are you? This is Andrea, and I added some slides to week 6 from my own personal experience. These are slides that I actually wrote up myself several years ago when I was working in the acute care hospital environment and needed to do some communicating with providers about different topics. And I think that they'll be helpful to you in the quality management class, and that's why I've posted them. But I wanted to add this video so that we could go through it voice to voice, so to speak. And here we are. The first one says, signs, symptoms, and test results are not diagnoses. And that is so true. Signs, symptoms, and test results are not diagnoses, but they do lead to diagnoses. So you use signs and symptoms and test results to come up with a diagnosis if you're a provider. But trying to use them in lieu of a diagnosis instead of a diagnosis doesn't work so well, especially for us in health information management. We need those diagnoses when it makes sense. So let's start out. Signs. What is a sign? It is what you see. When you are the provider and you look at the patient, what do you see? Do they look feverish? Do they look pale? Maybe do they look like they're having trouble breathing? Do you notice that they're coughing? Are they restless? Do they not seem to be themselves? Do they seem to have an altered mental status in terms of they're not answering questions? Are they having hallucinations? Do they see somebody or something that's not in the room and are addressing that? Maybe their skin color is off. Maybe it's heightened because of a fever. Maybe they're very, very pale. Do they have edema? When you're examining the patient and you look at their ankles, are they swollen? And if you press on them, do you notice edema? Is there edema in their belly? When you're assessing that, do they seem distended? Even an abnormal vital sign, such as low blood pressure or high blood pressure or a fever, those are all signs. Those are things that you can see. Symptoms, on the other hand, are what the patient complains of being wrong or the family has noticed and is wanting to share with you as to what's wrong as a provider. So it's, again, signs are an objective indication seen by the physician or by the provider. Symptoms are the perception of health by the patient or family. So an example would be chest pain. We can't measure chest pain as a clinician or a provider, but the patient can. The patient can tell you, I have chest pain. It's here, or it's radiating into my arm. It feels like it's difficult to breathe, those types of things. Headache is another one. That's a symptom. It's something the patient feels. We may not be able to see, and we certainly can't judge what they're feeling because we can't measure that, but we can ask them to explain to us what they're feeling, how bad they're feeling, what level is it to, how long have they had it. Shortness of breath. You can sort of see shortness of breath if someone's gasping, if someone is wheezing. Wheezing is more of a sign because you're noticing it, you can hear it, you can see it. But a patient will tell you, oh, I feel like I can't catch my breath. Nausea. Nausea is definitely one. We probably can notice facial expressions which may tell us someone is not doing quite so well and might not be feeling their best, and maybe they've got that green cast to their face and we might want to get them a little dish. But a patient is the only one who can tell you that they feel nauseous, that how bad the nausea is, those types of things. I mean, granted, if they start vomiting, obviously that's a sign, but the nausea is a symptom. Weakness. A patient can feel very weak. You can notice that they're having difficulty moving around or they seem unsteady on their feet. Those are signs again, but symptoms are something the patient has. So weakness would be a good one. Failure to thrive. That one you can see in the sense that someone may have lost weight. Someone may be pale. Someone may tell you they're not eating. Sometimes you see this with elderly people who have been married a long time and they lose their spouse. And after their spouse is gone, they have a really difficult time eating, having the desire to eat. And so they kind of fade a bit. But failure to thrive is something the family might tell you about, that they're concerned about. Altered mental status. You may notice that the patient's not behaving quite like themselves, that on previous visits they behaved in a certain way. Maybe they were very interactive, maybe they were attentive, and now they're very withdrawn, those types of things. And the family, again, can tell you, Mom just hasn't been herself, or Grandpa doesn't seem to be with us, or he's just not himself. It's something wrong. He's saying strange things. Those are all symptoms. So patient and family perceptions are symptoms. That's what they're telling you they feel or they see or they sense or they communicate. Signs, again, are objective things that are seen by the provider. So then what are test results? Test results are the outcomes of ordered tests and treatments. Example, now you're going to need to pull out your old medical terminology knowledge here, but leukocytosis, the result of a lab test. Hypoxia, hypoxemia, those are results of tests. Elevated troponins, that's definitely a result of a test. In and of themselves, test results cannot tell you what the patient's diagnosis is. When you match test results with signs, with symptoms, you can definitely come up with a diagnosis most of the time. But a test result is not a diagnosis. Someone can have elevated troponins and not be having a heart attack or an AMI. That's perfectly possible. So, you can have elevated troponins with stress and sepsis and other types of major infections and things like that. So it's not just, you can have elevated troponins sometimes with other types of diagnoses that are not necessarily a cardiac-based diagnosis. So you just want to be really careful when you're working with providers that if they're using test results as diagnoses, they should be using the test results to get to the diagnoses. But unless they really truly can't get to a diagnosis, then they can use signs, symptoms, and test results to document and for us to code. Tachycardia, bradycardia, ejection fraction, those are all test results. Again, don't necessarily mean that just that there's a diagnosis there. It's just that's the test result. High and low blood sugars. Taking someone's blood sugar, if they've got a high blood sugar or low blood sugar, that doesn't necessarily mean that they're diabetic. It may very well be, you may very well be dealing with a patient that's heading into diabetic ketoacidosis, but then again, maybe not. So you've got to be really careful about diagnoses, about using signs, symptoms, and test results instead of diagnoses. They really should be used to build diagnoses. So as you work with your providers, keep all that in mind. Diagnoses themselves, what they are is in the opinion of the highly educated and trained provider, the underlying cause of the patient's signs, symptoms, and test results. That's what it is. It's in their opinion. What are those signs, symptoms, and test results saying is truly wrong with a patient? A diagnosis may be possible, suspected, probable, likely. Those are all possible in the inpatient setting. It may be acute, chronic, acute on chronic, or unknown at the time of diagnosis. It may take a little while to get to the point where you can figure out, as a provider, where exactly they are at on that continuum. But if you've got someone who has a chronic condition, say chronic COPD, is this an acute exacerbation, or is this an ongoing part of their chronic COPD? It matters. Or is this an acute exacerbation on top of chronic COPD? All of that is that's very important to know, that specificity. Is it present on admission? Not present on admission? Unknown? Again, that needs to be addressed when a physician is providing documentation, especially in the inpatient setting. So some examples: acute on chronic respiratory failure, chronic systolic or diastolic heart failure, acute COPD exacerbation, suspected aspiration pneumonia. Now that's something you might see in a long-term care facility. If you have someone who has difficulty swallowing, they sometimes aspirate when they eat or drink, and that goes down they may end up with pneumonia, especially a bacterial type of pneumonia. And if this happens, typically providers will order a swallow study with a speech therapist to identify, do they need to make diet changes, thicken liquids, or, worst case scenarios, feeding tubes to address that aspiration. Because sometimes it is a sort of a silent, suspected aspiration situation that's causing their repeated pneumonias. Acute blood loss anemia. Oftentimes patients have that. And yes, you can see the test results with a low hemoglobin, but have they had a situation recently where they've had some acute blood loss? Have they been after surgery? Is it after a trauma or an accident, a broken bone, or some type of a wound where there was bleeding? Those types of things all play together. So you want to work with your providers and make sure that they're getting those types of things documented. Possible sepsis. Sometimes there is when a patient has an infection, could they possibly have sepsis? Occasionally that plays into the situation. So that's it for the first slide. The second one is averting code inquiries. This slide came out of physicians saying, why are you querying me again? And us saying, well, if you would document it in the first place, we wouldn't have to keep coming back to you and querying you. So pretty much if you run across any of these situations, just give us the specificity and we will not query you. But if you ignore us and you document and you don't give us that specificity, then you can pretty well be guaranteed you're going to get a code inquiry. So examples. We need providers to document the etiology of GI bleed if it's suspected, likely, identified. We need to know, where's the GI bleed coming from? Where do you think it's coming from? Sometimes it might be possible. Sometimes it might be suspected. Sometimes you have test results that tell you where the GI bleed is. We need to know. All decubitus ulcers, all those pressure ulcers, we need to know their present on admission status and their stage. So if someone's got a pressure ulcer, we need to know, was it present on admission? And what stage was it at admission? And then, of course, at discharge, we need to know again, is it still present at discharge and what stage is it at? Chronic kidney disease. Particularly if a nephrologist is consulted, need to know from a provider, what is that CKD stage? We need to know that because that plays into it, and we'll have to query for that. Cerebral edema and or brain herniation if the radiology results reveal it. If you've got a situation where you have those, we just need the provider to document those because that makes a big difference when we go to code. Acuity and type of CHF, congestive heart failure. Is it systolic? Is it diastolic? Is it both? Is it acute? Is it chronic? Is it acute on chronic? Those of you who have coded, you know that there's a big difference in codes for all those, and we need to know that when we're talking with providers. Microbiology results. It's great that they're in the chart. Wonderful. We're thrilled with that. But they have to be in the discharge summary in order for us to code those, unless you have hospital policy that states otherwise. And I would be really careful about that if you do. I'd make sure that you have it in policy form, what you do and what references you use to back that up, because that's a little bit on the gray, sticky side. I would not recommend it. I would recommend that you only code microbiology results if the physician includes those in his documentation. Same thing with pathology results. Really shouldn't be coding off the pathology report. We again need a physician to say, yes it is, no it isn't. Even though a pathologist is a physician, it really needs to be whoever is overseeing that patient's care that's documenting that. So hypertension, oh goodness, there's a big can of worms right there, isn't there? Hypertension. Oh, proper terminology, and of course this changes over the years, and so it's a challenge to providers to remember, which one am I supposed to be using? So we ask them not to use crisis, urgent, emergent, severe, or uncontrolled. Either tell us it's benign or tell us it's malignant. One or the other, benign or malignant. And if you're going to tell us it's malignant, you need to tell us, is the BP greater than 180 systolic, or BP is greater than 120 diastolic, or we have to have symptomatic end-stage organ disease, or symptomatic end organ damage. So make sure that if you're working with providers and they're struggling with hypertension, try and make sure that you get them to give you that information. And then there's good old angina and chest pain. If it is stable, please list likely or suspected causes. If there's stable chest wall pain, what do you think it is? Is it costochondritis? Is it shingles? If it's pulmonary, do you think it's pleurisy? If it's GI, do you think it's GERD? If it's or biliary or anxiety or hyperventilation or CAD, coronary artery disease, with or without angina. If it's unstable, we need to know if it's crescendo, accelerated. Note, does it happen at rest? Is it intermediate coronary syndrome, ICS? Because really, ACS is the same as unstable angina. So we really need that careful specificity. Again, these are just reference slides for you as you go out into the world, to help you with your providers and to help you if you're struggling with some of these things. This was very helpful to the people that I worked with, and that's the only reason I'm sharing them with you. The third slide is how do you make sure your reports are RAC resistant, meaning that RAC audits are inevitable. Unfortunately, they really are. Sooner or later, they will come to your door. And okay, how do you make sure that when they come to your door, you're ready for them and that you've got the documentation that you need to be able to fight them? The best way is through your H&P and your discharge summary, your history and physical report and your discharge summary report. Make sure that your providers are documenting severity of illness, prognosis at the current time, treatment difficulty, need for hospital intervention at either inpatient or observation level of care, and resource intensity. Those all need to be in your history and physical report. Discharge summary. What is the severity of illness, admission versus discharge? What is their prognosis at discharge? How difficult was their treatment during their overall stay? Their need for hospital intervention at admission and during the stay. Why did they need to stay inpatient when they did? Or go inpatient when they did? Resource intensity. What resource intensity was used throughout their overall stay? Why were they required to stay the days that they did? What were we doing for them that needed to be done in an acute care inpatient hospital setting or whatever setting you're working in? And again, this kind of works as well. You can distill this knowledge down to either long-term care or to physician practices or outpatient clinics. It may not be in a history and physical document or a discharge summary document, but you can easily put those in visit notes, and especially if they have a series visit where they're coming in multiple times, maybe for oncology services, make sure that those are addressed so that the payer and anyone who audits those records can see that consistently there was a need for those services and that they were met in the right level of care throughout the entire process. So then the next slide is a gastroenteritis example. Typically, gastroenteritis, if it results in an inpatient hospital stay, is going to be challenged in the hospital setting, either by the payer or by the government or by RAC or by somebody, because gastroenteritis is usually not considered severe enough to be an inpatient diagnosis. All right, so on the left-hand side it says observation criteria. On the right-hand side it says inpatient criteria. Let's say that you have been selected to do utilization review or to assist the provider in placing the patient in the most appropriate level of care. Maybe you're assigned in the ED and you're working with an ED doc who has a patient in for gastroenteritis, and the ED doc says patient's really not in a good place to go home. Do we admit to inpatient or do we place an observation status? Here is what we developed at an organization that I was at to help the doctors. This was a slide that they could keep in their work area whenever they had a gastroenteritis patient pull out and say, okay, do they meet OBS criteria? Do they meet inpatient criteria? And that helped them determine where they place the patient. So under OBS, they need to have at least one finding: BUN 25 to 45 mg/dL, creatinine greater than 1.3 to 2.0 mg/dL, urine specific gravity greater than 1.030, persistent vomiting that's unresponsive to greater than or equal to 2 doses of antiemetic in the ED. So if you have one of those, that's the minimum of what you have to have for that part of the OBS criteria for the finding. For the treatment portion, you have to do one set. You have to say, oh, this one's got intractable vomiting, so we're going to do a serotonin antagonist or an antiemetic plus fluid. And then it goes through all of those details. Serotonin antagonist greater than or equal to 1 dose, or antiemetic greater than or equal to 2 doses, plus IV fluid greater than or equal to 100 ml per hour, or IV fluid greater than or equal to 75 ml per hour with age greater than or equal to 65, or acute renal failure, or congestive heart failure. And if they have congestive heart failure, we need to specify the acuity and the type. So you either need to do that set of treatment for intractable vomiting, or you need to do the treatment for diarrhea, which is IV fluid greater than or equal to 100 ml per hour, or IV fluid greater than or equal to 75 ml per hour with, again, the age greater than or equal to 65, or acute renal failure, or congestive heart failure. And then again, make sure you specify the acuity and type. So to meet observation criteria, you have to have one finding and you have to do one set of treatment. If you can't come up with one finding and or they don't need either one of those treatments, then odds are the patient is safe to be released. But if you meet those, then you're going to want to keep the patient probably in OBS status. If you have a BUN to creatinine ratio that's greater than 20, active vomiting or diarrhea, inadequate oral intake, if you have all three of those, you meet the finding for inpatient admission. So let me say that again. If you have a BUN over creatinine ratio of greater than 20, active vomiting or diarrhea, and inadequate oral intake, you have met the findings for inpatient criteria. But you have to make sure that you do the IV fluids as treatment. One is required. Either you have to have greater than or equal to 125 ml per hour, or you have to have greater than or equal to 100 ml per hour with age over 65 or older, or acute renal failure, or congestive heart failure. And again, with renal failure and heart failure, you've got to talk about the acuity, type, severity. You know, if it's if they have chronic renal failure, that needs to be mentioned on top of it. You have to have one of the IV fluids. So either it's 125 mLs per hour, or it's the 100 mLs per hour with something else in it. If you meet all three findings, and you have one or the other of the IV fluids, you've met inpatient criteria, and you might as well admit that patient, because obviously this person is very sick and going to need intensive services. Maybe not ICU services, but definitely intensive hospital care. So the next slide that leads us to the next one is a level of care decision matrix. When do you do inpatient versus OBS for level of care? Where I was previously, you can see they had case management assistants available during certain hours at a certain extension. Just pretend you didn't see that. But what's below it is really what's important. And the question here, you start at the top left of the screen. There's 4 rows: severity of illness, location of care, intensity of service, ideal level of care. So your severity of illness added to your location of care, looking at your intensity of service will lead you to the ideal level of care. Let me give you an example. If you have someone who has symptoms only with or without chronic conditions, they just have symptoms only. You haven't been able to build a diagnosis. There may not even be one. They just have symptoms at this point. With or without chronic conditions, wherever they're at outside of ICU, they belong in OBS most of the time. So the recommendation is, if you've got somebody with symptoms only, whether or not they've got chronic conditions, as long as they're outside of the ICU, they really probably should be an OBS level of care. If they've had surgery, with or without chronic conditions, if they're going to an ICU bed, they need to be inpatient. If they are going to a non-ICU bed, was this an inpatient-only procedure, a Medicare inpatient-only procedure, then they need to be inpatient. If they're a surgery, again, with or without chronic conditions, non-ICU bed, and you're doing more than just monitoring, then they should also be inpatient for that reason. But if there's surgery with or without chronic conditions, they're in a non-ICU bed, it was not an inpatient-only procedure, or you're just monitoring only, observation is probably the more appropriate level of care. Then moving to the next set, surgery with acute conditions, or an acute diagnosis with or without chronic conditions. Again, if they're going to an ICU bed, they need to be inpatient. An exception to this rule where I was an overdose patient can be in ICU as OBS if the patient is only there for one-to-one monitoring, one patient to one nurse monitoring. So that was the only exception for someone going to ICU in an OBS status. Because typically overdose patients, they bring those back, they get them stabilized within that 24 to 36 hours, and then they're ready for whatever their next level of care is, usually in an outpatient setting or being transferred to a behavioral health detox or a detox unit, those types of things. So going back, surgery with acute conditions or an acute diagnosis with or without chronic conditions, if you're going to an ICU bed, you definitely need to be inpatient. Next one, surgery with acute conditions or acute diagnosis with or without chronic conditions, and you're going to a non-ICU bed. If it's a failed ED or outpatient treatment, if you have abnormal test results, if you're going to be doing aggressive care testing, IV meds, consultations by other providers, that patient really has earned their inpatient bed, their inpatient status. If you're just doing routine care, routine meds, no consults, they're in a non-ICU bed, then they're probably okay in OBS status. The last column is they have multiple acute diagnoses and or acute organ failures. It doesn't matter whether they're in an ICU bed, which you hope they're in, but whether they're ICU or non-ICU, they need to be inpatient. If you're dealing with someone who has multiple acute diagnoses and or acute organ failures, inpatient status, yes, definitely. So that's what that slide is about. I think there's just 3 more slides, not too many more. Hang in there. I'll try and pick up the pace a little bit. The next slide is on surgical complications, and this goes with Chapter 8 of what we're studying. The next 3 slides really probably go with Chapter 8 in what we're studying. What is a complication, a surgical complication? The definition of a complication is a condition that, when present, leads to substantially increased hospital resource use, such as intensive monitoring, expensive and technically complex services, and extensive care requiring a greater number of caregivers. That is taken directly from CMS. So again, a complication is a condition that, when present, leads to substantially increased hospital resource use, such as intensive monitoring, expensive and technically complex services, and extensive care requiring a greater number of caregivers. It is more than a routinely expected condition or occurrence, and there is a cause and effect relationship between the care provided and the condition, and there is provider documentation that the condition is a complication. That's a coding clinic definition. So you have to have both of those before it should be called or coded a complication. So what I used to train surgeons to do is document the occurrence. Is it accidental versus inherent? Some things are just inherent. If you're trying to remove adhesions from the bowel, you're going to have some tears. There's probably no way around that. That's pretty inherent. But if you're doing hysterectomy and you nick the bladder, that's definitely not inherent. That wasn't expected. That isn't a normal part of the process in the procedure, particularly if you have to call in a urologist to repair it. And how you handled it. How was it fixed? Was the puncture, laceration, tear, fracture, burn, hematoma, etc. accidental? Not expected, unlikely or unusual to happen based on surgical procedure being formed. So again, some examples that I gave were a bladder nick during OBGYN surgery, a lacerated bile duct during a cholecystectomy, a fracture during orthosurgery, puncture of an intestine when inserting ports for a laparoscopic approach resulting in conversion of procedure to open. Those are all accidental. They're not inherent. They're accidental. And they are all something that are going to require substantially increased hospital resource use to fix. So those would be examples, good examples of things that should be documented as complications. Things that should not be documented as complications, because was the puncture, laceration, tear, fracture, burn, etc. inherent? Was it expected? Was it likely to happen because of the surgical procedure being performed? An example would be enterotomies during extensive lysis of bowel adhesions, what I talked about. If you're gonna take those adhesions off that bowel, you're gonna expect some tears. It's inherent, and in many cases, it really truly can't be prevented, and you're just going to have to fix it. And some of those fixes are very, very minor, so they're easy to take care of. Then another example of inherent is a conversion of a procedure from laparoscopic to open due to the presence of thick intra-abdominal adhesions. There's not really a good way to test whether or not someone's going to have thick intra-abdominal adhesions. Now, if they've had multiple abdominal surgeries, yeah, you can kind of expect that. But sometimes, some people do, some people don't. And if you go to do a laparoscopic procedure and you run across this and you have to convert it to open, it's nothing that the surgeon did. It's just they have that condition, and because they have that condition, it's going to result in a need to convert that procedure to open and move forward. That's not a complication. Normally, when someone has to convert from laparoscopic to open, it has the potential to be a complication depending on what the situation is. But if it's something that's particular to that patient's anatomy, it's inherent. It's not a complication. It doesn't meet the definition. So there you have it from a surgical perspective. The next slide is non-surgical or medical complications. Again, the definitions don't change. CMS's definition doesn't change. Coding Clinic's definition doesn't change. It's still whether it's a complication or whether it's inherent and not a complication, and when do you document it. So what should be documented from the medical side of life? That you need to document the occurrence. And was it present on admission or not present on admission, and how was it treated? Was the complication already starting at admission? Was it not present and didn't show up for 24 hours after admission? It could not have developed prior to admission if it's 3 days into the stay. Those types of things. Example, if you've got a pressure or decubitus ulcer from skin breakdown or wound dehiscence, it worsens after admission, that's a complication. A DVT or a PE that's developed post-op, that's definitely a complication. A fall with trauma, Unfortunately, there are still some times where patients have falls in a hospital and they end up with a fracture or some kind of trauma, like a major hematoma, or a significant skin tear that has to be repaired. Those are examples of medical complications. They have happened during the patient's medical stay. They're not a result of a surgical procedure. A CAUTI or a CLABSI, that's a device-associated infection. Unless the patient comes in with their catheter and the UTI is diagnosed as coming from that catheter and being present on admission, if 3 or 4 days into the stay they develop a CAUTI, a catheter-associated UTI, urinary tract infection, that's absolutely a complication that has occurred while they're in the hospital. And just because you put in a catheter does not mean a patient should have a urinary tract infection. In fact, the opposite is true. There are many, many patients who have catheters who do not develop urinary tract infections because that's best practice. That is the appropriate way to do it. CLABSI is another example of that. That's a central line bloodstream infection, or a central line, bloodstream infection. So if you get a central line in and you've got an infection and it's traced back to that, was that central line put in prior to admission? Could that infection have happened prior to admission and just was noticed a day in? Or did the central line go in on this admission and a couple of days later we see some kind of infection coming from that? So those are some examples. But when they're device related, it's important to know, was it present on admission, was it not, and when the device was put in, but also how that is. Because if a patient comes in without a device and we give them a device and then they get an infection on top of it, yeah, that's our complication to own. Poor glycemic control or hypothermia. Sometimes those things happen depending on what's happening with the patient. Doesn't necessarily make it a complication. But there are times when those do occur and they are a complication. Because it may end up that the patient has to go to ICU, they're here longer, there's more consults involved, different things like that. So that gives you an idea about medical complications. The very last slide is about FPPE and OPPE, and we talk about that in HIT 445, especially on week 8. Week 8? No, week 7. Week 7. That's this week. So, what were some things back in the day when I did FPPE and OPPE and was responsible for medical staff services? What were some of the things that we did, that we reported for FPPE and OPPE from an HIM standpoint? We looked at chart delinquency trend. Did they have suspensions? Did we have to send them frequent reminders to get their records done? Even if it was electronic world, we still tracked that. Did they use unacceptable abbreviations? QD, IU, those types of things. Did they use abbreviations in their diagnoses on the discharge summary? Which, of course, is a classic no, not to be done. Then we did a contents audit on all H&Ps. We looked at timeliness, family history, diagnoses. Were those types of things there and were they appropriate? Operative report contents, those audit findings, were they timely? Were there complications? Were they documented appropriately? Discharge summary content audit findings. Was the discharge summary timely? Did it talk about the patient's condition at discharge? Did it give us a full complement of diagnoses? Those types of things. Post-procedure progress note trends. If they didn't dictate the op report right after surgery and they had to do a post-procedure progress note, did they do it on time? How long after that was the op report dictated? And did they perform it when an op report was dictated? Because some providers used to try and escape the OR before doing either a post-procedure progress note or the op report. And then they'd come back later, like the next day, and they'd do both. So it was looking at the timing on all of that. Recovery audit contractors, that's RAC, take backs and trends. Did we have any of their cases where we had to pay them back because of documentation issues? And then we looked at code inquiry trends. Did we have specific diagnoses that we had to repeatedly query with specific physicians? And then another piece with code inquiry trends were, did we have physicians who didn't respond to code inquiries? You know, that ignored them forever. And even if we tried to track them down, I'm not answering that. Those types of things. And then we had what we called standards of behavior and patient safety indicator compliance, whether that was excellent or whether it wasn't. And we really looked at, are they treating staff, particularly HIM staff, with respect, and are they responsive to HIM staff requests? Have we received any complaints from our individuals, our teammates in HIM about physician behavior, about their willingness to work with our team? Because really, we're on the same team with our providers. We want to work together. We want to make it easier for them to practice, but we also want them to meet the standards that we have to meet for regulatory and other purposes. So this was our way of educating the medical staff up front to say, okay, you need to be aware that when you come up for credentialing or for re-credentialing, this information is being provided as part of the FPPE process, OPPE process, and it will go to your department chair. And we will produce it. I think we produced it every 18 months for this process. But the goal was that HIM would have that feedback put into FPPE and OPPE for consideration with those processes. We really wanted to make sure that that was happening. So that's what all this information is. It's entirely, it might be helpful. I hope it's helpful. And I wish you all well. Stay warm. We'll talk again soon. Bye.